this is a very exciting topic for me, and I devoted my life to learn how to deal with ectasia, to prevent it and to treat it in the best way as possible. I do work with some companies, including Oculus and other companies. I also have a Violet June international global campaign for bringing awareness to patients with keratoconus. We know that the first part of the treatment is patient education. We need to help these patients the best way as possible, and learning about the disease, that they cannot rub the eye, for example, and when and how to do the surgery is fundamental for them to have the best care as possible. Uh, I also have some collaborations with my colleagues and friends from the BRAIN, the Brazilian Artificial Intelligence Networking in Medicine. We completed 10 years last year, and we have some work that should be in the future available in the market. I also put together a masterclass, which is coming to be international. And if you see this QR code and the bit.ly RA masterclass, you have the opportunity to subscribe and eventually get a selected PDF series of articles that I wrote as a gift there. When we think about ectasia, the first thing is that it's not a new disease. We have records of that many, many years ago, since the early times of ancient medicine. But the first description of keratoconus was about 150 years ago by Dr. Nottingham in England. And this description is very important for us because it brings us into the understanding that there is a disease, that the cornea gets an abnormal shape that distorts vision. But it was when we had the introduction of laser vision correction in the late 80s and refractive surgery with incisional keratotomy in the mid 80s that we saw the explosion in the number of publications. It's very important that we acknowledge this and eventually understand the relationships of refractive surgery, laser vision correction, phakic IOLs, cross-linking, and all the procedures that we'll discuss for the developments of keratoconus. And that's why I wrote this editorial, that we broke some paradigms and we create some paradoxes, which is related to when and how to do the procedure. So the role of refractive surgery is unquestionable for many parts of ophthalmology, and eventually we have to face that refractive surgery is an ally and an enemy, because when we do the procedure, we can weaken the cornea and have a subclinical ectasia become clinical, or make a real normal cornea to be unstable because of the weakening caused by the procedure. So refractive surgery made us improve the diagnosis. We had also clinical treatments and surgical treatments that are available that benefited many parts of diseases, not only elective laser vision correction or refractive surgery, but in any situation with disease in ophthalmology. I really like this understanding from the Art of War, which is a very ancient wisdom from Sun Tzu, that we need to understand our enemies and ourselves so that we have more chances to win the battles in this life. When we put this wisdom into ophthalmology and refractive surgery and keratoconus, I would say that what we are trying to do, we try to get the early diagnosis, we need to get prognosis, we need to understand the severity of the disease, stage the disease, and classify the disease. We need a more detailed follow-up so that we can get conscious decision if there is a progression or not. We need patient education and orientation, and the imaging that we have will be very important for us to guide the treatment, since refraction up to contact lens fitting, customized surgical planning, evaluating post-op results, seeing complications, and this complex conundrum of imaging tests that starts with slit lamp biomicroscopy, central corneal thickness, placido disc topography with ocular surface imaging. We have Scheimpflug tomography. We have whole eye wavefront data. We have ocular scattering. We have ocular biometry, which is important for us to understand the myopia of the patient, segmental tomography, which is related to the ability to see the epithelium. We have corneal biomechanics. We have the ability to see cells, not only the endothelium with the spectrum microscopy, but stromal cells, corneal nerves, and epithelium. And more, we face the opportunity to understand molecular biology and genetics, and that will provide important inputs for us. This is all together in the concept of multimodal imaging that I refer to refractive surgery, and this is an evolving concept, and this is a truly evolution in evolution, a revolution in evolution. A few years ago, I was honored to co-author this editorial for the Journal of Refractive Surgery with the editor, Dr. Brad Rendeman, and we put together an editorial that the question is what we are screening for. And we are screening for ectasia risk, not for keratoconus. Ectasia risk is different than keratoconus. Of course, if you have the disease, the risk of having the disease will be much unquestionable, but we need to understand ectasia susceptibility. But when we manage patients prior to keratoplasty, and here is the paradigm shift that we had when I did my training in ophthalmology in cornea, keratoconus was only treated in surgery by a penetrating keratoplasty, and that was in the late 90s. Today, we have many other opportunities to help the patient, and we broke these paradigms and we create paradoxes, and those are related to when and how to do the procedure. So screening for ectasia susceptibility is different than diagnosing the disease, staging, and the clinical management and follow-up. When we think about multimodal imaging, I like to think about some opportunities that we have in the industry. I do consult for oculus, and we have, for example, the Pentacam family, and I started working with the Pentacam in 2003. I received my first one in 2004. The first Pentacam evolved to the Pentacam HR. Then we had an AXL module to use optical biometry, and now we have, along with AXL, we have whole eye wavefront data with a Hartmann check sensor. So this is multimodal imaging, and we have this opportunity to understand the complex data, and we have to display that. The displays can be seen in many different formats, and I like the understanding of the histograms. For example, angle closure glaucoma, not related to keratoconus itself here, you can get the angle closure glaucoma risk based on the anterior chamber parameters that we have. Of course, when we think about keratoconus, you refer to the Bell and Ambrosio enhanced ectasia display that I'll try to give some inputs about what we have done and what we should do and can do in the future, in which we include the great work by Michael Bellin, Professor Michael Bellin from the University of Arizona in the United States on the enhanced elevation understanding and my work on the thickness profile. It's important to understand that the D is the deviation from normality, and that was set for a normal population, not for patients that undergo refractive surgery. So if you had the procedure, you probably have the thinning from the procedure here, and this is not going to work. This is for pre-op cases. We also have the nice contribution from Michael Bellin on the ABCD. A and B are front and back surface curvature around the thinnest point. C is the thinnest point, and D is the deviation from the distance correct visual acuity. And you can see the threshold for significance so that we can see if the patient had a progression or not compared to the baseline. So it's a very important information. But when we think about keratoconus and refractive surgery in ectasia, we go for the concept of iatrogenic carotectasia. This was first described after Lasik in 1998 by Professor Seiler. The first 3 cases with progressive ectasia after Lasik for high myopia. Those days we were considering Lasik for patients with more than 10 diopters of myopia, and those cases were severely weakened by the procedure. We now have the limit for optical quality and etc., but those cases had Lasik ectasia due to high myopia treatment on the cornea. A few months later, the iatrogenic carotectasia in a case of foam fruits keratoconus defined as foam fruits based on the front surface topography. So those are alluding to the two pathophysiologic mechanisms of ectasia. Biomechanical decompensation of the cornea can occur if the cornea is weak, as the second report, and also because of the impact from the environment. And of course, laser vision correction procedures weaken the cornea, and the question when we screen for ectasia risk is if the cornea can undergo the thinning and the weakening by the procedure and still be stable over time. But the concept is that any cornea may develop ectasia if you weaken the cornea above or below making the cornea unstable on the concept of the post-op procedure. But if you want to avoid ectasia, it's very simple to start by telling people not to rub the eye, because eye rubbing is the major cause of ectasia progression that we see today. And that's the concept of the campaign. Violet June is a keratoconus awareness campaign. And if you understand the sentence that eye rubbing or scratching the eye or sleeping over the eye aggravates keratoconus, but may even cause ectasia, those are very similar in many of the clinical settings, but are not exactly the same. Aggravating keratoconus and causing ectasia should be differentiated because it would impact the prognosis, it would impact how we handle the clinical situation, and understanding that may even help with further familiarity and patient education. Brad Brenneman did a nice contribution on the ectasia risk score system, and he put together a score that goes beyond topography. Topography, the front surface curvature, we can have a normal symmetrical, asymmetric bow tie, inferior stiffening, and abnormal. Here he put abnormal as foam fruits keratoconus, and here I would say, and I'll mention my understanding, which is a little bit different. But the nice contribution is to put together different aspects of the screening process, including residual stromal bed, post-op residual stromal thickness of the cornea, age, which came as a surrogate, is a true surrogate of corneal biomechanical properties, and thickness, and along with level of correction. But we have 20 years to put together this editorial a few years ago, 20 years actually after the first report in 1998. So we have a conundrum that came in a very nice work by Dr. Bohak. She did a very nice series of 30,000 LASIK procedures, and she had 10 cases of ectasia. And these 10 cases of ectasia were very hard to be understood in terms of why they undergone ectasia. Only 3 out of 10 had residual stromal bed lower than 300, not even 250. And 2 out of 10 had a PTA, the nice work by my colleague and friend Marconi Santiago, who pointed to the fact that the percentage of tissue altered of more than 40% may be a better indicator for ectasia risk prior to surgery than the residual stromal bed. But the question here is, the fact is that we had cases of ectasia with lower risk, and we need to improve our ability to understand that. So the concept is enhanced screening for ectasia risk, and another nice work with 300,000 LASIK procedures by Steve Schallhorn. He were able to see cases with ectasia with a normal topography, 30% of ectasia cases, and eventually 1% of the stable cases had an abnormal tomography. So here we point to the fact that we have to enhance sensitivity and specificity for the detection of keratoconus and ectasia risk. So the point is, what is ectasia susceptibility? What is foam fruits keratoconus? And in my opinion, these are the same thing. But the point is on foam fruits keratoconus is that the long understanding of keratoconus fruits has a lot of misconceptions in the literature. So Jan Rabinovitz, who I am honored to collaborate in some of the work that he has done with OCT and topography, he would say that the patient with abnormal topography but normal distance correct vision and normal slit lamp will be the foam fruit. Steve Kleiss, who I also had the honor to collaborate with, would put in a brilliant editorial in 2009 in the British Journal of Ophthalmology that the fellow eye from patients with very asymmetric ectasia, eventually called unilateral keratoconus, which is a misleading term in my opinion as well. I would say those are very asymmetric ectasia cases, but the fellow eye with a normal topography from these asymmetric cases will be the foam fruste. The nice systematic review by Maria Enriquez and Luis Izquierdo from Peru, they saw the huge variability on what is foam fruste keratoconus and what is subclinical keratoconus in the published English literature. So it's important to understand that there is no consensus. We tried to do a consensus on foam fruste keratoconus, and that was one of the aspects of the consensus that we did not reach an agreement. So since Emsler, Krashmer, which would say this is a mild disease, the fellow eye, there is no consensus. My humble contribution is that foam fruste keratoconus should be defined as a patient with a high susceptibility for ectasia progression. And I first wrote that in 2009, but I found this paper that I presented at American Academy of Ophthalmology in 2008 on ectasia susceptibility detection based on tomography and biomechanics. In this year, I debated with in the Cornea Day on elevation versus curvature. And Doug Koch presented this beautiful case with a brilliant lecture on the importance of curvature, that this patient would have abnormal curvature. And this patient eventually had subbauman keratomiliosis, which is LASIK with a thin flap, and the patient developed ectasia. And this will be abnormal sign. Eventually, we looked at this case and we decided to do a study on the subjective variability of the classifications. The classifications on subjective domain is very variable. And if you send these 25 topographies, this is front surface topometric maps from patients to experts, to colleagues that do work with refractive surgery, with corneal topography, and ask them to classify first with the 1.5 diopter absolute scale and then with a half a diopter normative scale, the classifications based on the Randleman criteria would be very much varying. So this was case number 6, and the first scale, the very classification from 0 to 3, but the mode was 0. In the second scale, it was varying from 0 to 4, but the mode was still 0. So we have a we should address, and eventually subjectivity is important, but we have to understand the limitations and improve the subjectivity with more objective metrics. So I like this quote from Albert Einstein that everything should be simple, but not simpler. We should respect what we have as the simple things in life, and eventually live much better along with them. So we have to work and develop a way of analyzing the data. And this was exactly the time that we were developing the Bell and Ambrosio enhanced ectasia display, which combines the enhanced elevation from microbellin and the thickness profile. And this patient had an abnormal D, which is a 2, higher than 2, and also a lower Artmax, lower than 400. So there is no cutoff exact. It's like a range of cutoff values, and this range is coming from different studies depending on the populations that we set, but this will be the best thresholds that we have. But what is the accuracy? We also can get this accuracy in different possibilities, but if we are trying to detect ectasia susceptibility and understand which patients are going to be stable after LASIK, we have the pre-op stable LASIK cases from a population that had LASIK, and over 2 years they are stable. So we have the pre-op data from these cases, 3,278 patients. And we have ectasia cases, 105 eyes. And here is the classic IS value, the Iaron-Rabinowitz, and this is very low sensitivity. But as expected, this is a very high specificity because the surgeons tend to look at this for not doing surgery. So it's important to say that this is not from my clinic, it's from an international pool of patients. And the D score, which was not available when these patients were operated, the D score had a about 60% sensitivity if you change a little bit the threshold to a little lower than 1.4, but the specificity is 90%. So the understanding of the concepts on what is corneal diagnosis came in a maturity with a very nice work from Bernardo Lopes. Bernardo Lopes did his PhD in the Federal University of São Paulo, and I helped him in this process. And we looked at the objective parameters. We first understood the disease versus non-disease issue. If you set the disease for keratoconus, you train the system to develop and evaluate the opportunity to the ability to see keratoconus. But we want to say, what is a susceptibility? So the pre-op of ectasia cases will be there, and eventually also the foam fruits, the normal topography eyes, the very symmetric ectasia, normal topography eyes. So we looked at ROCs, which is a statistical test to see the accuracy, and also we can combine with artificial intelligence. That with what we can do for improving the algorithm for clinical implementation. And he developed the Pentacam Random Forest Index, which based on the same data, we improve either the sensitivity and specificity. But we still have cases down here that can be explained by the understanding of the impact from the procedure, but eventually we need to go beyond. And going beyond tomography goes to the domain of corneal structure understanding, corneal biomechanics. Corneal biomechanics in the cycle of the compensation of ectasia is eventually the first phenomena. And the first phenomena should be detected in the clinical setting. And our work is to combine the understanding of corneal shape and corneal tomography and corneal biomechanics. Today, we do corneal biomechanics measurement with the Corvis ST. The Corvis ST is a high-speed non-contact tonometer that takes in 31 milliseconds 140 frames. And this high-speed data would develop a lot of metrics, and these metrics include the deformation of the cornea, the velocity of the cornea, and we can see measure the central versus peripheral, the DA ratio, and the area for the inverse concavity. So this should be combined with a detection index, that is the CBI, the Corvis Corneal Biomechanical Index, which was very nice work done in collaboration with Paulo and Ricardo Vinciguerra. And Ricardo Vinciguerra, we were proud for him to get the Troutman Award in 2017. And you can see the differentiation of a softer and a stiffer cornea based on these metrics. We also have the relational thickness on the horizontal because we have one Scheimpflug image, so we can get the thickness profile through the horizontal for the understanding of the art age. The combination of tomography and biomechanics is, though, the TBI, which is a random forest as well for artificial intelligence, and the ARV, which is in Estonian, is the number. This is the Ambrosio, Robertson, Vinciguerra, and this is come from trees. In Portuguese, ARV is arvore, and this means trees. And in Estonian, this is the number. So we wanted to really have one number to summarize the complex data that we have from tomography and biomechanics. And this is the histogram, the dot plots, which is easier to see than the histogram for, you see the separation from normal versus clinical ectasia and the mild subclinical ectasia. Those cases were considered normal topography based on a strict topography objective criteria, KISA less than 60, IS less than 145, and central K less than 47, and no TKC detected. And if you change the threshold for 0.29, you improve the sensitivity to about 90%, keeping a very high specificity. So this is, in our opinion, an epitome for ectasia susceptibility. This is a normal cornea with a high susceptibility, and eventually you have to understand those cases down here. If you do a segregation analysis here, you see that we have 3 types of cases in this group, and we have to learn more about this. So let's see a case that came as a candidate for laser vision correction. She was 2015 with minus 2.75 and minus astigmatism, 27 years old. Topography and tomography, you see the topometric maps are pretty much the same. This is the Ambrosio 2 scale. And this patient was pretty much normal. But when we see the abnormal TBI more than 0.35, 0.4, this patient is abnormal. And tomography is borderline, but biomechanics is abnormal. The fellow eye of this patient is a mild keratoconus. She has 20/25 distance correct in this eye, and eventually she came as a refractive candidate. So this is a very high susceptible for ectasia, which I would say is a form-fruit keratoconus in the right eye and a mild keratoconus in the left eye. However, we can have unilateral ectasia. Unilateral ectasia, the best example is this patient. The patient presented with clinical ectasia in the right eye. He did very well with a corneal ring segment. This is the differential map. And the patient moved to London. And when he moved to London, I asked him to see my colleague and friend, Professor Dan Reinstein, who has done one of the best works in corneal imaging that we have on this planet with ultrasound for measuring the epithelium. Actually, today we can measure the epithelium also with the OCT, but he's pioneered on this work. And he has an algorithm that was normal in the left eye of this patient. Dan has also a very nice prolific work on his clinical examination, and he still uses the orb scan. And we got the data from the orb scan and then sent to my friend Damian Gatinel and Alan Saad, which concluded in the score analyzer that the left eye was also normal on orb scan. This patient was seen on tomography and biomechanics, and you can see the TBI was 0 that time. In 2014, we had the data, but we didn't have the algorithm, so we have to back calculate the algorithm. But when he came back a few years later, he was still normal in the left eye. So this is a true stable unilateral ectasia in the left eye. So the concept is that in the global consensus, we came across some very nice conclusions. We didn't have a consensus on what is form-fruit keratoconus, but we found that true unilateral keratoconus does not exist. And I love Star Wars, and this is a very nice wisdom that came from Master Yoda. Keratoconus is bilateral. However, we agree that secondary ectasia may be caused by a mechanical process, and it can be unilateral. I remember very well when I debated we should add this small sentence here. It can be unilateral. So ectasia is eventually unilateral. But if you have keratoconus, the genetic disease, the disease is bilateral. And then we have an example, a very nice example. The first twin sister was a very asymmetric ectasia, abnormal in the right eye, very mild, 20/25 distance correct vision, 20/20 plus in the left eye. And then I said, it's interesting because we have some data to support that based on topography, you would say that you have only the disease in the right eye, but the tomography, you have abnormality also in the left eye. And then she said, you should see my sister. Okay, you have a sister, it's interesting. But I have a twin sister. And then I said, you have a twin sister. Is she identical? Yes, we look exactly the same. And eventually she said, we looked exactly the same, but I did have more allergy than her. And she developed more allergy in the right eye. The TBI of the 4 eyes are abnormal, even both eyes from the identical twin sister. I first sent this genetic material to the Avellino company, which came with a very nice conclusion with a lot of data to say that they are twins. And I said, this is not going to be helpful for me. But a few years later, they developed a very nice work on the Ava gene for keratoconus screening. And eventually we found that both of them have ectasia susceptibility. So if you think about the concept of having a gene have the epigenetics and the environment influencing the genetic profile of the patient, and then having a clinical situation that will be influenced by all of this, this makes a complete sense. So tell people not to rub the eye. Very nice work by my colleague and friend Shizuka Ko from Japan. She published 3 daughters from a patient that had mild keratoconus, And all the three daughters had a distance correct vision better than 20/20. And they have some interesting findings on topography and the integrated tomography and biomechanics. And I would say this is a true way of understanding the susceptibility, and telling people not to rub the eye may save them from having the disease. A very nice work and contribution from Dr. Hari Shetty, who leads a great group in India on the understanding of lysyl oxidase and other parameters that we can get. And in the future, I do believe that we will have a diagnostic kit on the molecular biology that would help us to understand what is environmental disease and what is the genetic susceptibility of the patient. So looking at inflammation, looking at extracorneal matrix remodelers, and eventually we would be able to understand in a better way so that we can treat and have a better customized planning. Let's see an example. This patient, the whole concept is to go beyond but not over. This patient is a 53 years old that came as a refractive surgery candidate for presbyopia. And he is 20/60 J3, 20/30 J3. If you see topography, the front, when I say topography is the front surface curvature of the cornea, this is the topometric map from the Pentacam, which is pretty much similar than topography. If you see placido disc topography in this patient is exactly the same, but you see abnormal in the right eye. So this is a good case that you say topography is sensitive enough to detect abnormality in a patient with a normal slit lamp and normal distance correct vision. Interestingly, the abnormality in the left eye is a little bit subtle in the posterior cornea, but when we look at the Bell and Ambrosio, it's a relatively normal D. This patient would say that is a normal D, but in the TBI, you see 0.64. Of course, the right eye, which has clinical keratoconus, topometric keratoconus, is a subclinical but topometric keratoconus, you have a D of 1.0. But this patient also have lens dysfunction. And the shine fluid imaging will help me very much on the analysis of this lens. The lens dysfunction is a different aspect of refractive surgery. Actually, the holy grail is to understand and treat presbyopia. But I would say this patient is still on the stage 2, and it's not the best for him to remove his lens. We can debate about that, but eventually, with better imaging, we can say when we come from stage 2 to stage 3, which needs the loss of quality of vision, and eventually he would benefit from intraocular procedure. And of course, when you have loss of high contrast distance correct vision and severe loss, it's not difficult to indicate cataract surgery, but we need to have objective data. So this patient was advised to wait, and eventually he's coming back for doing his phaco refractive procedure in the right eye, and eventually that data will be important for us to select the best IOL for him, which in my opinion should be a spheric IOL. This other patient is a different situation. The patient comes with 20/30, and you see this is the Pentacam wave. You see the back scatter of the cornea. You can correlate the shine fluid imaging with the retroillumination, and you have this data also in the left eye. So this patient has a mild cataract, but when we see this in terms of the quality of vision, we have to understand also tomography. And this patient has an interesting situation. She has inferior stiffening. She never heard about the word keratoconus at all in her life. And eventually, you can see some abnormality also here in the back of the cornea, in the endothelium. And this corneal optical densitometry will be important because this patient has a second spike, which is in the camel sign, the second hump on the camel sign, which is related to guttae. So she has mild guttae, 72 years old, pretty unquestionable cataract, and this patient has mild keratoconus as well. So this patient should be advised to do surgery as soon as possible for having the lens removed when she's not still when she's more soft and not so hard, so that we can do a phaco procedure with less trauma and having her endothelium to be not traumatized and having the cornea to be clear after surgery. So it comes to a different aspect that I decided to include in this talk, even though it's about ectasia, but I think tomography, we have two diseases in the cornea that may be a subspecialty. First, I think keratoconus, and second is endothelial disease, Fuchs dystrophy. Very nice work by the colleagues from the Mayo Clinic, led by Dr. Patel, that determined the subclinical edema signs in tomography. So you have the loss of the isopax on the thickness mapping, the deviation from normality, the displacement of the thinnest point, which is pretty much in a normal patient, pretty much in the paracentral area, and it goes to the nasal, inferior or superior area, and the depression. Here, I prefer to use a different color scale. I do not pay a lot of attention to color scales, but I prefer to see blue on blue. And here he uses a scale that gets a depression in the red. And we put together a commentary on ophthalmology for this brilliant paper, including the thickness profile, attenuation, the camel sign, the blue on blue, and the correlation with the thickness of the decimates level that goes beyond the shine fluid to the OCT. That is a good indicator for prognosis in endothelial disease. And we published a couple of reports on the importance of screening for ectatic disease prior to multifocal IOL. Eventually, it's a top leading cause of exchanging the IOL in these patients. And it is important also to understand that keratoconus may be associated with guttae. And eventually, keratoconus in guttae may be a good thing, so that the disease that thins the cornea and the disease that thickens the cornea may be counterbalanced, but eventually up to the point that the disease gets progression, you can get a more complicated situation in which you need probably to undergo a penetrating full thickness corneal keratoplasty because of the disease in the both levels. Very nice work again with Shizuka, that she got the idea to look at the corneal abnormalities in the patients that would undergo cataract surgery, and she saw the benefit for understanding tomography and biomechanics to enhance the sensitivity and specificity for these patients. So we need to look at the cornea before cataract surgery, and keratoconus is also relevant there. But everything is not only keratoconus. This patient came as a candidate for phaco with multifocal IOL, and this is a cataract with low K keratoconus. So this patient, the keratoconus is not a problem. She had this stable for her life, but understanding the characterizing the low K keratoconus is important for us to, with a normal slit lamp, but very much abnormal. And about 10 to 15% of the clinical keratoconus have a low K keratoconus. This is a very important concept. This is based on topometric irregularity, tomographic irregularity, and biomechanical irregularity. So low K keratoconus is when you have a keratoconus that is with a steepest K lower than 46, let's say. But these patients, they do have keratoconus, and enhanced integration will be important for us to develop the best method for selecting the IOL. Another situation is a patient that came for cross-linking. This patient came referred for cross-linking in my clinic. And the patient has a progressive astigmatism. He comes with a nice summary of his glasses that were increasing astigmatism. And you see, this is the multimodal imaging from Essilor. It's 1700, which is done by the Visionix, very nice company from Israel that does a very nice work with the topography and whole eye wavefront data. And you can see that the integrated, this is the curvature of the cornea translated to wavefront metrics. This is the total whole eye wavefront that was also measured with the Hartmann check. And you see the internal wavefront is much more related to the total wavefront than to the cornea. So it's interesting to see that the Hartmann check has some shadows here. And the Hartmann check can be correlated with this imaging when you dilate the pupil. Here is very obvious, but this patient was being counseled for having cross-linking. And if you see the anterior chamber depth, which is asymmetric here, this patient has a thin cornea with an inferior stiffening, but the problem is in the lens, is a sublux lens, and this patient would not benefit from cross-linking on the cornea. Eventually, cross-linking the zonule would be interesting, but we don't have this available, and this patient should be counseled not to have cross-linking in the cornea, actually to follow up the cornea, not to rub the eye for many reasons, but eventually understanding what is not keratoconus. When we think about ectasia susceptibility, this is one of the best examples that I have. This patient had ectasia in the left eye after LASIK and decided not to do surgery in the right eye. We published this case about 10 years ago, and this case is still stable. And if you see topography of the right eye, is very much similar to the topometric maps on the Pentacam. The BAD-D is borderline, the PRFI is borderline, but when we go to the integrated tomography and biomechanics, we see such abnormality. So this is important to understand that ectasia susceptibility can be detected by that. So I'll come with another example from my clinic from which I learned tremendously. This patient came as a candidate for laser vision correction, -9.5, actually a candidate for refractive surgery. We do comprehensive refractive surgery, not laser vision correction only. And this patient was presenting with a suspicious, not suspicious, but relatively normal. Everything is on the green, but you have Artmax, which is the parameter that interestingly have my name on it. That was the only thing that would be abnormal. But we decided to do a SMILE for her. And SMILE caused ectasia. That was the first ectasia that I had in my career. And looking at this is the 2 years follow-up. You see some abnormality, 25 plus, 2025 plus, very happy, everything stable. But this will be a very interesting indicator for early. The fellow eye, the left eye, is pretty much stable. But once we have clinical ectasia in the right eye, we have to be very careful for the left eye. But when we see the posterior elevation here, you set the posterior elevation for the same best fit sphere of the pre-op. You see the difference here will be detectable for ectasia. So we have to be looking at the posterior elevation in these cases. Why this patient does not have ectasia in the left eye? Because of the epithelial thickness. Here you see a clear thinning of the epithelium on the area of the bulged cornea. This patient has stigmatism, loss of this correct vision, and we have to treat her. I really talked to her about what happened. I told her verbatim like this: I devote my life to prevent this problem, and in my career, that's the first time that I had. I explained to her that we should treat her as soon as possible for the right eye because she was getting worse. And we have to be careful in the left eye not to rub the eye and do oral riboflavin, treat the allergy, and eventually did the procedure. She did very well. This is the 1 year after corneal ring implantation with an intrastromal riboflavin. She improved uncorrected and distance corrected vision, came to 20/20, and you can see the epithelial thickness evolution here. And also you can see the ring, very nice ring placed here, and the difference in the biomechanical metric. This is the ectasia and after ring plus epi-on cross-linking in this case. And you can see the demarcation line in the center. We do have cross-linking happening in the center in this technique. So the fellow eye is stable. Ricardo also developed a very nice CBI for laser vision correction. So we have a CBI option for saying that the patient had LASIK or SMILE PRK, and this patient is still stable. So we came from SMILE to frown, back to SMILE again. But I did learn that this patient had an abnormal TBI. We had the data, We didn't have the algorithm. The surgery was done in 2014, and in 2014, we developed the TBI in 2016. The paper was published in 2017, but this abnormality here would have lead me to do a phakic IOL. What about specificity? Specificity in this case. Look at this patient. This patient is at 52 years old with inferior stiffening. She has 20/20 plus, a normal tomography, normal endothelium in both eyes. We did LASIK, topo-guided blended vision with 4.5 years follow-up, very happy patients. And this is the pre-op with inferior stiffening. If you change this scale, this gets pretty much red here. And eventually, this tomography data will enlighten me to do the laser vision correction with a femtosecond LASIK flap. And the retrospective evaluation, she would say, also in the domain, because we didn't use the tomography and biomechanical index because it was not available when I did her surgery, but it's nice to see the retrospective specificity here. So this is a stable LASIK, 5 years follow-up, and this is an ectasia after SMILE, 4 years after SMILE. So if you just look at the cornea and ask which patient would develop ectasia, probably you look at your attention. This is forced to be 1.5 diopter scale from Steve Kleiss and Mike Smolik, and you see that you have to go beyond the surface. Another case that developed ectasia after SMILE, and you got the pre-op data with, even though a very green topography, 20/20 discorrect vision, and the patient developed ectasia. So it's important to look at the TBI as an indicator, or look at the tomography data, to look at the data that you have, so that you can say if the cornea can undergo or not laser vision correction, phakic IOL. We have ICL and IQ phakic, and we have eventually some cases that will be in the domain for therapeutic surgery. I like the wisdom from Neil deGrasse Tyson, knowing enough to think we are right, but eventually not enough to know you're wrong. And I think about that for myself many times, actually all the time. And we saw some papers in the literature that some colleagues and friends, eventually, they started looking at cases that the TBI was not so accurate that they published many of these papers. So the ROCs are lower, the sensitivity eventually will be much lower. So it gives us the opportunity to understand that artificial intelligence for keratoconus diagnosis is a revolution in evolution. So in a larger series, we have now from less than 100 to over 500 VAE and T cases, and those cases were pretty much in agreement with the BAD-D published reports, and we proved the algorithm with a new function that will be available soon that improve the sensitivity and specificity for both the subclinical cases and for the clinical cases. So we should have it soon. Another case report. This is a very interesting, very recent case report from this week. The patient has clinical keratoconus in the left eye. The right eye is very much normal. Changing the scale, a lot of people say, Renato, your scale is not so good. Let's use, this is the classic Atlas scale, the half diopter absolute scale that's very popular, at least in the United States, and very normal in the right eye. And this patient has very symmetric ectasia. So the first thing is that how the advanced imaging may help. The first is to help detecting clinical or subclinical or clinical aspects of abnormalities here. Patient has normal topography, eventually a thin cornea, but this is a foam frost. So the enhanced diagnosis confirmed the mild frost disease in the right eye. What about the prognosis? This is the left eye when I first saw the patient, and you see the SPA1, which is the stiffness parameter developed by Cynthia Roberts, very, very low. And eventually, besides the age, I told these very low biomechanical parameters would indicate risk for progression. And the patient comes back and he lost a little bit of this correct vision. But interestingly, you see the Kmax did not increase, actually decreased a little bit. But if you see the differential map here, in this area, you have a little thicker red here, so you have a stiffening here. Even though the Kmax did not increase, there was a stiffening. And if you see the nice work by Michael Bellin, you see A, B, and basically almost C, you have an increase, and there's an unquestionable progression. This patient needs cross-linking as soon as possible, in my opinion. So advanced understanding is to understand objective data, ancient intelligence along with artificial intelligence applied, understanding what we're trying to achieve, and this revolution in evolution. But let's talk a little bit about the treatment of keratoconus. It's important to say that when we do the diagnosis, we educate the patient and we go for the treatments, and eventually surgical treatment should be done for visual rehabilitation and for stability of ectasia. So we have many opportunities to help the patient in surgery for keratoconus, and we should understand that when we need to do surgery, the surgery should be done as soon as possible. And when we need it, when we have a patient that is not happy with his vision, with distance correct vision with glasses or contact lenses, or it's not working well, or when the patient is having a progression. I don't think we should do cross-linking in every patient. We should tell people not to rub the eye. We should give oral riboflavin and treat these patients, but understanding the conundrum. Whole eye wavefront data can help you for improving refraction, and I have started doing that early when I came back from my fellowship in the United States with the ray tracing technologies. You can have auto refraction, super wavefront auto refraction. There's another example that they optimized manifest refraction that this patient had. We can improve vision and eventually see the confirmation based on the multimodal imaging and stability on tomography. So the treatment is visual rehabilitation and starts with glasses. Contact lenses are the best way to improve vision, unquestionable. There is no refractive surgery that can beat a good, well-fitted contact lens. But contact lens is not for having the stability of the progression. This is not the opportunity that we have with the contact lens. Interestingly, if this contact lens is not well fit, the likely progression will be accelerated. And this is part of our consensus that this does not halt the progression, and eventually cosmetic contact lens should be disencouraged for these patients because we know this can cause more trauma and accelerate the disease. So family education is a must. Allergy control, guidance for the patient for not rubbing the eye is a must that every ophthalmologist should embrace in his practice. I do believe that omega-3 and riboflavin can improve. Riboflavin-rich diet. Interestingly, I think a lot of people love to rub the eye like this. This is the eye rub. This is a video on the YouTube, the eye rub, and the guy is rubbing, and one of the comments asking, do you have keratoconus? And interestingly, we should tell people not to rub the eye. Just rub against the caruncle. Arthur Cummings, my colleague and friend from Ireland, he has a very nice video that teaches you to rub the eye against the caruncle without scratching the eye. Damian Gatinel has a brilliant career and many contributions, and he would say that sine qua non for keratoconus eye rubbing is. I would say that eventually is not so simple like that, because if it would be the case, telling people not to rub the eye, we would have keratoconus prevented all over the world. But we have patients that are very weak, and those cases, they may progress even with mild or no eye rubbing. And understanding that eye rubbing is a 100% consensus that we should tell people not to rub the eye is the most important fact. So telling people not to rub the eye is going to be very important, and that's a major part of our Violet June campaign, which I hope you get sensitive to embrace in your daily practices. This is an old video from my fellowship, the Cornea fellowship, that my transplants I did, a penetrating transplant. This is a nice work by Dr. Francis Price from Indianapolis, one of the best cornea surgeons in the planet, and on the lamellar, deep lamellar keratoplasty. I also have done some work with the femtosecond laser. This is one of the first IEKs that we've done with a modulated incision. And eventually, we have to understand that the femtosecond gives you the opportunity to put the rings. From all the indications for femtosecond applications, that's the only one that I only do with the femtosecond. We can combine laser ablation, custom laser ablation, the nice work by John Kanellopoulos with the Athens protocol for regularizing the cornea along with cross-linking, and eventually combine that with a phakic IOL. And the combination of procedures like in the Athens protocol and the therapeutic bioptics should be understood. And those cases, they typically have a very deep anterior chamber, so you can go for the anterior chamber AOLs, but we now prefer the ICL and the IQ phakic, even though we have a nice displacement for placing an anterior chamber IOL. So we have to understand the two reasons for doing surgery and eventually consider that refractive surgery is not the main first thing in our minds for treating a patient with keratoconus. Eventually, you can help those patients with elective procedures, but we should be careful, and that's why Bart Simpson is here putting his work under the duty. And therapeutic and refractive surgery are not exactly the same, and I like this correlation of the genetic similarity of a lion and a small cat. They have more than 95% same DNA, but very different phenotypes. And eventually, the understanding that if you treat a patient that has keratoconus as a refractive patient, you may have a big trouble, and eventually the opposite as well. Cross-linking is a great contribution. I do believe that it deserves a well-deserved for a Nobel Award for Theo Seiler and his group. Started in Dresden and then going to Germany. We have a lot of publications on cross-linking, and interestingly, collagen cross-linking is not a good term. It's a corneal cross-linking. The intracellular matrix is not only worked on the collagen level, but also in a more complex way. We have the Brazilian rings, and we have Intex. Nice work by Ricardo Guimarães, Walter Nozé, and Paulo Ferrara that you know well, the Ferrara ring and the Brazilian ring. And we have, as I told you, the many possibilities for putting the femtosecond laser in our practices. That's the only one that I do exclusively, even though it's very much doable to use the dissectors for doing the ring. But the predictability, the safety, and the overall safety and efficiency of the procedure with a femtosecond. I have worked with different femtosecond lasers. This is a must for a corneal ring implantation, in my opinion. I do indicate sometimes the injection riboflavin in the tunnel, and if you do it with patients, you can get riboflavin in the center of the cornea and have epi-on cross-linking. This can be done. We can get different ways of planning the ring. There are modulated thickness profile rings, and I do believe we are just scratching the surface on this capability. Medifacus has done very nice work on giving us some options with the asymmetric rings, which is a thin and thick with 160 arc, but even with a larger arc, which gives us the opportunity to treat the asymmetric disease with an asymmetric thickness rings. And this is one of the first examples that I treated. You can see the deeper, thicker segment here would have a more pronounced effect in this situation. So finalizing the keratoconus paradox, the 2020 paradox is related to vision. We are not facing refractive surgery for keratoconus. We are facing therapeutic procedures, and we are evolving. Keratoconus is a new subspecialty. Ectasia is a new subspecialty in ophthalmology. If you understand that scratching or eye rubbing causes ectasia and aggravates keratoconus, if you understand this sentence, probably most of the knowledge that I try to give to you is related to this. We have broken paradigms related to the how to treat these patients, but we created paradoxes because elective procedures in keratoconus should be done with care. Eventually, keratoconus surgery is the the procedure that we do for helping the patient should be understood along with the patient. So individualized medicine and patient education with eventually some role for artificial intelligence to take the wisdom from the thousands of data that we have from the clinical practice with multimodal imaging and clinical scenarios so that we can get the best plan as possible to help the patient. And eventually understanding that we should be still human beings, still doctors, and individualized medicine goes with the wisdom that we heal sometimes, we relieve often, but we should always comfort our patients. And that's related to patient education, to the complex work we do with individualized medicine, with all the technology that we have, and eventually to help the patient the best way as possible. So I thank you very much for your kind attention, sharp on 1 hour, and I look forward to some discussion with you. Thank you.
All right. Thank you so much, Renato. What a superb lecture, Renato. Amazing and amazoning presentation. That was mind-blowing. Fellow ophthalmologists, now we are approaching the question and answer session. There are so many questions from our participants. Those are considered as one of the most curious webinar attendees on this earth. May Winnie help me to read each question to our maestro. Winnie, please.
Thank you, Doctor. All right, now we begin to start the Q&A session. The first question is from Dr. Sharita Siregar from Jakarta Eye Center. She actually has 2 questions. I'm going to read the question number 1 first. Maybe you can answer question number 1 first, Prof. Dr. Prof. Renato Ambrosio. Question number 1 is, dear Prof. Renato Ambrosio, as we know, there is some study that mentions the problem in keratoconus is on the Bowman layer. So that's why some corneal surgeons did Bowman layer transplantation in order to increase the strength of cornea. Do you have any opinion regarding this? Thank you, Doctor.
Well, thank you. Thank you very much for the question. The cornea has basically 3 layers: the epithelium, the stroma, and the endothelium. The front part of the stroma, we have the Bowman's layer, which is a more dense structure which is probably the strongest part of the cornea. The anterior stroma will go less and less weaker, stronger. The strongest part of the cornea is the front part, and the strongest is the Bowman's layer. So just implanting a thin Bowman layer may help some patients, and we have seen some encouraging work by some colleagues, starting from the work by Garrett Mellis, who is probably the most brilliant mind in cornea that we have in our generation, and many colleagues like my friends from Sorocaba here in Brazil, they have done some work on that, and we are seeing the possibilities that we have for different transplants. So I would say that the problem does not start on the Bowman, but the Bowman is probably a very important landmark for the disease in terms of diagnosis. We have some work done with a group from Bangalore with the OCT that we published that the Bowman's regularity may be a very important indicator for keratoconus diagnosis, for ectasia susceptibility diagnosis. But the lamellar transplants, I would say that can be helpful for helping some patients. But as a refractive surgeon, I prefer not to put layers in the cornea because it creates irregularities in the optical system. So in my opinion, the Bowman transplantation may have some work for therapeutic cases, but if you try to improve the best vision as possible for the patient, I would say it's hard for them to be better than a good, well done DALC. But we should wait and see more clinical data. But I would say that Bowman layer is not the cause but is definitely a reactor, is a consequence of the disease. And eventually learning how to see with OCT, high definition OCT data of the Bowman layer and the epithelium stromal thickness profiles will be keen for enhancing our diagnosis.
Thank you. Next question.
All right. Thank you, Professor. Next question is still from Dr. Sarita. Her second question is, what if our hospital don't have any pentacam or corpus? Maybe you can tell from the clinical symptoms, is there any predictors that can be used as a predictors for the probability of ectasia post-Lasik? Thank you, Doc.
Thank you. The wisdom from the art of war will tell you that you should know yourself and know the enemy. The enemy is ectasia. We want to prevent ectasia. And thinking about my learning process on the refractive surgery, I started doing with a corneal topography and central corneal thickness. And it's doable to do refractive surgery with this. Yes, it is. But you have to be very careful on indicating a lamellar procedure that weakens the cornea more in patients that you don't have a tomography or biomechanical data. So I would say if I were you, I would be more conservative in doing more surface ablation with mitomycin C than doing LASIK or even SMILE. But I would say that LASIK should be done when you have confidence that the cornea can afford the weakening caused by the lamellar cut, which is much more impacting than the laser ablation. So I'm not giving you the wisdom to say do PRK in everybody, but I have done, if I would say that, I may put myself in a different situation because when I did my first procedures, we didn't have the pentacam and I was using the keratome for doing LASIK, and I did few hundreds of these patients, and this is not wrong to do like that, but you just have to be more careful on selecting the patients with the thickness. Look at the endothelium, look at central corneal thickness, and look at the distance corrected vision, look at the age. Be careful with patients younger than 35 years old, which is the number that I would say the best separates the aging that the cornea gets still to be weak. But I would say that refractive surgery is an elective procedure. And if you want to do it, you should consider having the proper technology for the best screening if you want to do laser vision correction with a lamellar cut, for example. But you can do it. Just be more careful, and I would be more prone to do surface ablation in those cases without the data.
All right. Thank you so much, Renato. The next question from Germany. How much PTA matters in prevention of corneal ectasia?
We have developed an algorithm called the RTA. RTA is relational thickened altered. And this is going to be related to the thickness of the cornea. This is going to be related to the age of the patient. And this is going to be related to the weakening that you cause by lamellar or surface ablation. The idea is to understand and to measure and to quantify the impact from laser vision correction on the cornea. And that's very good. So my colleague and friend Marconi Santiago did a very nice work to point to the fact that residual stromal bad is not the only factor that we should see. Actually, if you see my first publication ever in 2001, it's a lazy complication review. We put together all the complications about LASIK. And when we talked about ectasia, we discussed that half of the cornea will be better than the residual stromal bad. Actually, this is not called PTA at that time. We called the half of the corneal thickness. So if you have a patient with a 600 micron cornea, you should leave at least 300, not the 250. The nice work is to see that we have to consider the impact from surgery. So if you think the impact from the procedure and how the cornea can handle that impact, those are the two factors. Unfortunately, the series that we have on ectasia, the PTA of 40% is not so sensitive to detect ectasia risk in this population, as it was in Dr. Bohak's paper and some other series that have been recently published. So I would say consider that, but this is not finalized. We have to do more complex computing and eventually using uh, some artificial intelligence along with finite element models, we may come to a better parameter. But eventually, telling people not to rub the eye possibly is as important as to do all these fancy calculations.
Thank you, Professor. The next question from USA, from Dr. Navinki. Regarding corneal ectasia, do you use contact lens after doing LASIK in low residual stromal thickness?
If I understand this right, he's asking if I use a contact lens for low residual. I don't understand the question. Contact lens is for optical rehabilitation is the best way of helping a patient with ectasia, regardless if it's a primary ectasia or laser vision correction related ectasia. I would say that patients with mild ectasia that have distance correct vision with glasses should be eventually avoid contact lens. But I don't understand the question. If maybe he's referring to a thin cornea that has a cross-linking with a contact lens, which is something that Susan Jacobs nicely described a few years ago. But today I prefer to use the protocol from Hafezi. But I really don't understand this question. Sorry for that.
Maybe LASIK in low residual stromal thickness. Maybe the residual thickness between 250 until 300.
Oh, see, if we have a patient that had LASIK and has a residual refractive error, I would say that we have to be careful on enhancing this patient. Enhancing this patient, you should look at the thickness of the cap, the geometry of the cap, and in my opinion, biomechanics is very important. But I would say surface ablation is a better procedure for those cases. So if you have a residual stromal bed after LASIK, consider doing surface ablation. And mostly if you don't have an OCT or high frequency ultrasound to measure the flap thickness.
All right, thank you, Professor. Next question is from Dr. Victor Nainggolan from Indonesia. He has two questions. I'm going to read question number one first. Dear Professor Renato, from the slide about the gene marker that you showed before, maybe you can tell more about the marker that exactly used as a predictors for dystropia.
That's a good question. I hope I have more clinical data and experience to share with you, but this is very new. I do believe that genetics should be opening the door for a lot of understanding in everything in medicine. Eventually, everything we deal with medicine, starting with coronavirus pandemic, if we have more knowledge on genetics, will be much better for us. But when we think about genetics and keratoconus, we have different types of genes. The genes that make the patients more prone to inflammation, to ocular surface inflammation, and some other genes that are related to the thickness of the cornea. So those two levels of genetic information may be eventually telling us that we have different diseases that we call keratoconus. We may have clinical disease as keratoconus in different pathophysiologic mechanisms. But though the genes that were found in the twin sisters were related to inflammation. So eventually, I wouldn't say that this genetic profile would say that this is a non-genetic keratoconus, but truly a more higher predisposition for inflammation and eye rubbing, and eventually this inflammation may have caused the ectasia in the right eye of the first twin and the susceptibility in all the other ones. So we are learning. And I think the beauty of genetic studies, excuse me, is if I have a patient that had ectasia after LASIK, I am really interested in seeing detective to find this data, calling the clinic and having, having the data found in old paperwork from the patient. But the genetic data is there. It doesn't change after LASIK. So genetic studies for laser vision correction related ectasia are going to be very easy to be done. You just need to do the genetic profile today. You don't need the pre-op data. So I would say that I can predict we have an explosion of papers and information about genetics and keratoconus in the very near future. And eventually some of them will be more confusing than elucidating, but we have to keep and distract for finding the best way of using this technology and learning how to help the patient the best way as possible.
Thank you, Professor. Still questions from Dr. Victor Nainggolan. His second question is about, maybe you have some data that shows the percentage of presentations of patients that showed ectasia from the procedure LASIK versus the relaxed smile.
Well, I like SMILE very much. I think SMILE is a great procedure. Probably I really agree with the prediction from Seiler that in 2014 he was elected the most influential ophthalmologist, and he said that SMILE will be the major laser vision correction procedure for myopia. And I think it's coming to be true today. SMILE has many advantages, but SMILE is not perfect. But the SMILE is getting better and better. Even though SMILE is much newer than LASIK, we have similar results. And SMILE has a lower weakening than LASIK, but if you screen a patient for laser vision correction, I would say that today you have to be as strict as you are for LASIK as you are for SMILE. PRK is not the same. PRK has a lower weakening than lamellar cut, and PRK can be a safer procedure. So if you put together the literature on SMILE and LASIK, you will probably see that there are more cases that had SMILE-related ectasia that had an obvious mild keratoconus pre-op. We put together a letter after the report from my colleagues from Egypt, Dr. El Nagar, and he was keen to share the U12 files of the Pentacam with me, and said, this is a clinical mild a mild low-K keratoconus, unquestionable before surgery. So the incidence of laser vision correction related ectasia will be probably around 1 case out of 3,000 procedures. That's the best incidence that we have today. This is still enough high to make us motivated to keep ourselves in working to predict and to reduce it, because we see patients, borderline patients every day. Maybe because I have a more patients tend to be sent to me with more borderline situations. But I think if you have any question, don't make that cornea unstable. Go for surface ablation or phakic IOLs. That's my major consideration for you to consider. Not doing a lamellar cut, even with a femtosecond LASIK or SMILE, if you have a weak cornea. And this weak cornea can be detected by front surface topography, can be understood even starting from age, which is not specific, because you can get at 20 years old that's a very strong cornea, but eventually age is a very important factor if you don't have the other data. Actually, we demonstrated that with artificial intelligence. If you have more data, age is going to be thrown as a non-considered parameter. But if you don't have the biomechanical data, age comes into the into the one of the top parameters that you consider. Is like a good surrogate, but it's not as specific. But the incidence is going to be lower and lower, but still there.
Thank you, Professor. The next question from Dr. Tolani from South Africa. What activity should be reduced for patient diagnosed with corneal ectasia?
Can you repeat the question? It was, I missed a part of your first part.
What activity should be reduced for patient diagnosed with corneal ectasia? Activity, daily activity, yeah.
Oh, first, telling people not to rub the eye. First thing, not to sleep against the pillow, against the eye. That's the first wisdom. But I think these patients can do everything. People ask me if they can go scuba diving, they can go, I would say probably there is no clinical data that can support anything like that. But I think they can have a pretty normal life, especially if they have a good fit contact lens. If the patient has progression, I would say consider doing cross-linking as soon as possible. And there are different ways of doing cross-linking. We still have a little more art than science to say what's the best way of treating this patient, with rings, with Tel Aviv protocol, Athens protocol, Cretan protocol. If you just do scrape manually, if you lift a little bit of the flap and do riboflavin injection with Epi-on, if you just do Epi-on, I would say that if each case should be understood in the best way as possible so that you individualize ectasia treatment. But these patients have to be counseled. And the first thing actually is to understand what the patient is going through, because there are different ectasias. There are ectasias that the patient is getting worse and worse, and you have to do as soon as possible. And some other cases are pretty much stable. And eventually learning about the patient and having they learn about the disease is the first combination for us to go forward in the best way as possible.
All right, thank you, Professor. Our next question is from Dr. Morteza Mortazavi from Iran. He has 3 questions. His first question is, can you tell what is the relations of BAD display and corneal diameter?
The corneal diameter doesn't play any role on the ABCD. Corneal diameter is going to be very important for the reference for the best fit sphere, but eventually we have changed a little bit the algorithm for hyperopic and myopic, which you can play. So the ABCD and corneal diameter doesn't have a much relation, but it's a very good question. Thank you for mentioning the diameter. Is very important. Actually, we are learning about diameter. We have the white that we see on the pentacam and on any caliper that you can do at the slit lamp. And you can see the angle to angle, and you can see internal behind the iris with high frequency ultrasound. And eventually learning those dimensions along with axial length and ACD, we may learn something about ectasia as well.
Second.
Right, thank you, Professor. Still from Dr. Morteza, you mentioned about low K keratoconus. What about hyperopic keratoconus?
Axial length is very important for that. We have seen hyperopic keratoconus since my fellowship. And I remember when I saw a case report on hyperopic keratoconus in the JRS, and I said, wow, I should have published that many years ago. But hyperopic keratoconus is very rare, but we are seeing more and more. And eventually hyperopic keratoconus gives you the understanding that you have to look at the axial length. Axial length is a must. Axial length is a must for a kid that comes with myopia for your clinic, that you want to follow her myopic progression, and you want to see axial length and elongation, and you want to see the case. Hyperopic keratoconus is possible. I would say that 3 to 5% of my keratoconic population have hyperopia, and eventually if you look at axial length hyperopia, it will go probably to 35%. But the steep cornea would get this patient to have a myopic refractive error. But hyperopic keratoconus is a very interesting fact, and looking at the axial length also gives you some keen information for planning the intracorneal ring or whatever procedure you want to do for keratoconus.
Thank you, Professor. Still from Dr. Morteza Mortazafi from Iran. His third question is, how do you consider against the rule astigmatism and refractive surgery?
I have some, I learned when I was learning Lasik, my mentor, one of my first mentors in Lasik, Dr. Peña in São Paulo, he would say that against the rule of astigmatism will be something that we should be careful with. And I think we have little data to say that against the rule of astigmatism is a weaker cornea than with the rule of astigmatism. I would say that you have to look at the topometric profile of the cornea and thickness profile of the cornea, but against the rule in a young patient is a yellow light that comes into my mind, especially when I see that the against the rule on the refraction is not explained by the against the rule on the cornea. So it's something different going inside the eye, or maybe the back of the cornea, the lens, or the vitreous, whatever the astigmatism is. You see, like against the rule of astigmatism on the refraction, and you have some mild with the rule on the front surface of the cornea. Those cases are very strange, and I would be very careful with those cases.
Thank you, Professor. The next question from Australia. Is there any surgeon's maneuver that tend to lead to corneal ectasia?
Thickness of the flap, unquestionable, yes. The thickness of the flap is very important. The thickness of the flap is probably the most important factor, and so consider doing it intra-op measurement of the thickness of the cornea when you lift the flap and you see the residual stromal band, especially if you're not using a femtosecond laser. But I would say there is nothing you can do to make the cornea more stable doing surgery and not related to the treatment. When you do the keratome cut, you learn, especially depending on the keratome type, if you put more pressure, you're probably going to keep deeper cut. So that may be one of the possibilities, but thinner flaps are always more preferable because of the lower incidence of ectasia in those cases, and eventually those cases you have to be more careful with the flap repositioning for having microstria, but it's much more planning than doing the procedure.
All right, thank you, Professor. Next question is from Indonesia, from Dr. Amanda Nursinta Pertiwi. She asked, is there any specific corneal conditions in populations over the age of 40 years that can cause deviations in the outcome of laser vision correction?
Yeah, it's a multifactorial situation, but of course, yes. I would say the more data you have and the more analysis you do, you'll find these correlations. But the first thing is to consider individualized patient data for planning decisions. But I do think so. And eventually, if you consider different cultural, different environmental, different genetic populations, you find some differences, and those differences are small, but they are eventually significant.
Thank you, Professor. The next question from India. So, is there any eye drops that accelerate or inhibit the incidence of ectasia?
Well, that's a great question. We have some very interesting things coming. Every meeting we talk about some different technologies that we have for chemical cross-linking, and there are some things coming into the market related to lysyl oxidase, a copper mechanism, and we hope this is coming to the market to help our patients. But the first drops that should be considered are the drops for allergy control, antihistamines, anti-allergic drops, eventually steroids, eventually tacrolimus for the patients that have severe allergy, ocular surface optimization with artificial tears. But if you think about enhancing corneal cross-linking with drops, I have used riboflavin in drops. My colleague and friend Luca Gualdi from Italy, he brought me some samples and I got some patients to buy from Italy, and then we have some pharmaceutical companies doing it in Brazil. And eventually I prefer to use oral riboflavin along with omega-3 for giving this oral supplementation of nutrition factors. But we hope to have some cross-linking treatments available for the patient to take at home, like put a couple drops every day or one drop every week. We don't know about how it's going to work, but this is definitely doable, and I'm optimistic to see this coming to the market soon.
Thank you, Professor. Next question, still from Dr. Siregar. Professor, maybe you have opinions about Lasik Extra, please?
I have opinions. That's a great point. I usually, people that work with me, they know that I say, this is my opinion and this is a fact. My opinion is that Lasik Extra is not going to help much. When we have a meeting in 2014 in Brazil, and Professor Seiler came as a guest, and he delivered the Barraquer lecture for the Brazilian Society of Refractive Surgery. In this lecture, he put nicely that it would be hard to prove that Lasik Extra would be beneficial for preventing ectasia. He would say that we would need a follow-up for 10 years and at least 10,000 patients in each arm for proving that Lasik Extra is better than Lasik without cross-linking. Eventually, I would say to him, we just need one case of ectasia after Lasik Extra to say that it's not a bulletproof procedure. And eventually, less than 6 months later, I was seeing this case be published by Sunil Tuni in the JRS. So Lasik Extra can lead to ectasia, and this is a case that was very much borderline. He did Lasik Extra because of age of the patient, and everything was really normal. And after that, the good thing is that he did a regular Dresden cross-linking, which worked for this patient. But Lasik Extra is not the answer, in my opinion. Lasik Extra would give you some false security to undergo LASIK in patients that are not so prone for having LASIK. So his opinion, though, is not a fact. But the fact is that there is a case published with Lasik Extra. Smile Extra is going to the same direction, and I have some very good colleagues that do LASIK, do Smile Extra in the borderline, and they publish some good results. But I would say that this is my opinion. I don't do it. I think cross-linking is a marvelous procedure for change the new horizon for helping people with keratoconus, but it's not for everyone. And this is a therapeutic for preventing progression in patients with clinical ectasia. That's my opinion. But there are some interesting data on Lasik Extra for hyperopic procedure, for high myopic procedures, and these patients may have some benefit from this procedure, but I don't know, I really don't have a real clinical perfect answer for you, a scientific answer for you. It's my more opinion. I don't do it, and I don't recommend it.
All right, Professor, thank you for the answer. Still from Dr. Sharita. It seems like Dr. Sharita is very interested in your presentations. Thank you, Dr. Sharita, for your enthusiasm.
Thank you.
Dr. Sharita question is, can we repeat the crosslink procedure? Is there any special way to do repeat crosslink, Professor?
Oh yeah, no, I have repeated crosslinking in a few patients, and people used to refer to the word failure in different ways. Failure is part of life, but a failed cross-linking is when the cross-linking was done and the patient kept progression. But if you are going down on a road 150 kilometers per hour, going down very, very fast, and then you push the brake and you start going down 25 kilometers per hour, you're slowing. You are not stopping, you are not reversing, but you're going slower. So the cross-linking, if the patient has a very severe keratoconus and it's a true keratoconus with a very weak cornea, and I do believe that the biomechanical and the multimodal imaging domain can help you for getting this prognosis, you may need cross-linking to be repeated. I have done cross-linking twice in many cases, but I don't recall doing a third time. And eventually the second time, the patients do better. And of course, there are cases that need a transplant, that those heroic cases that you have to be very careful on advising that you are doing a procedure in a very high, steep cornea, thin cornea, and the chances for having a good result are very much lower, and you have to educate these patients about it. But you can repeat cross-linking, for sure you can, and eventually you must.
Thank you, Renato. The next question from Pakistan. Do you have any experience patients suffering desmetocele after LASIK and how to deal with it?
Yes. Tell patients that it's going to get better and better. So you're talking about this photopsia. There are rainbow glares, and there are glare with starburst and halos. The rainbow glare is related to the path of the femtosecond laser, that you have some lines, some different femtosecond procedures, instruments would be more prone for that. And eventually, when we see that, you tell people right from the surgery that you see some color rainbows around some lights, and that's normal, and you get better and better. And eventually, some patients, they make fun of it. Oh, I see that sometimes. I think it's nice. And I'm glad you say that, because I thought I can get some hallucinations. But the halos and glare with quality of vision is a long topic. I usually more bothered about that when patients complain about it. With custom ablations, it's much less common. And when I see a patient with a large pupil and some high order aberrations, I really like to show them they have it. So I project a point of light in the room, and I show them with the glasses that they have, with light and turning light off of the room so that the pupil can expand, and I show you already have this. And eventually most of the patients would say, I never noticed that. So having that in the pre-op may be the best way of having the patient understanding they already have it, and they will deal much better with that after surgery.
All right, Professor. Next question, still from Iran, Dr. Morteza Mortazavi. Do you consider IOP as a risk factor for progression of keratoconus?
Cool, Morteza.
Thank you very much. Very good question. Very good question. I think it is important because the ectasia is related to the biomechanical stability of the cornea. So you have the eyelids, you have the extraocular muscles. So you have all of this changing the stability. And intraocular pressure is one of the pressures that the cornea has to handle. So I have seen patients decrease the curvature with IOP lowering drops. This is not very much predictable. I have seen that happening a few times. One other aspect is that if you Google pigmentary glaucoma and Lasik Ectasia, you find in the International Journal of Keratoconus, one of the reports that we have is related to that. And this patient had a pigmentary glaucoma along with ectasia, and lowering the pressure changed tremendously his vision and his corneal shape. We have other situations that this happened as well, but pigmentary glaucoma and ectasia may be an interesting topic to be considered. It's one of the things that I didn't have time to mention in my talk, but it's a good question. And also, patients with a weak cornea and a weak sclera, they may, and high myopia and ectasia, they may be in a higher predisposition for severe glaucoma. This is another thing to be considered. So when you see a patient with ectasia, with keratoconus, and I thank you for allowing me to say that, you have to consider the patient have overall health of the eye to be considered with glaucoma, peripheral retina, everything should be considered.
Thank you so much, Renato. The next question from Sweden. What kind of corneal imaging device is the best imaging in screening of possible corneal ectasia?
Well, I have financial disclosures related to Oculus, so you must, I have my name on the Pentacam displays. But I would say the best screening device is the one that you have at your clinic, the one that you have good confidence on analyzing, and the one that you have available for you to screen this patient and to continue the follow-up. But if your question is, I'm starting a new clinic and I want to invest on the technology, I would say the Pentacam is the standard for that. The Pentacam standard is very good. You just need to have this for tomography data, and you can get tomography evaluation. And the new displays that we hope to have soon will be giving you all the Pentacam random forest and everything else. But if you ask me how can I predict the imaging technologies for the future, I would say the multimodal imaging will get better and better. We already have axial length and whole eye wavefront data, and eventually the next step is epithelial thickness to have integrated. But the best imaging device is the one that you have confidence on analyzing it. The one I use is the Pentacam. I use the Pentacam, I still use the Keratograph 5, I still have wavefront data that with Hartmann check and ray tracing technologies and OCT technologies of that. And integrating Corvis and Pentacam has given me much better sense for the artificial intelligence and the analysis. But Galilei is a good instrument. The MS-39 is a very good instrument. We have many good instruments in the market, and all of these instruments, if you properly learn how to interpret the data, they may work well for you.
All right, Professor. Talking about collecting the data from Pentacam, what about Sirius topograph? Are the reading data regarding keratoconus is the same? This is a question from Ala Paduka from Moldova.
Yeah, if you the topometric data, the front surface curvature data from the Pentacam and the keratograph are very similar. They are not exactly the same, but they are very similar. And eventually, you have to see the cutoff values, the level of sensitivity and specificity. And if you get the files that I put in the file folder for you, you get the topometric tomographic table with the cutoff values. If you Google topometric tomographic Ambrosio, you find the table easily. And this is something you have to keep in your hands or eventually memorize for interpreting the maps when you have it.
Thank you, Renato. This question from your neighbor country, Argentina. In what cases you use contact lens after surgery?
I use soft lens for surface ablation in every case for the first week, and that's pretty much it. I don't use it for LASIK in the routine care. Eventually, when I have some abrasion on the epithelium, I put a contact lens in, but I usually don't use it for lamellar procedures. I just use it for surface ablation.
Right, Professor. Still question from Dr. Ala Paduka from Moldova. What about trans-PRK? Are the rules for patient selections the same for LASIK?
I like trans-PRK. I love it. Actually, I do it since 2008. It was the main reason for me to move from the Vuzix to the WaveLight platform because of the ability of having a PTK and doing a PTK PRK procedure. One of the main reasons for that was, and it was 2007. Today we see some platforms integrating PTK PRK in commercial planning devices, and I think it's great. I think it's great. I did my fellowship with Steve Wilson, and Steve Wilson gave a very nice contribution for the understanding of corneal wound healing. And if you remove the epithelium with a laser, you may have some benefits on the wound healing response because you remove the epithelium along with the cytokines, and that's going to be beneficial for the second and tertiary events on corneal wound healing response. So I do it for every surface, most of my surface ablations, and I do the epithelial thickness with the OCT for planning the PTK mode. I still use the regular PTK on the WaveLight, the X500, but the nice Streamlight is also a very nice procedure. But the point is that they still don't do custom ablation with the PTK. But you have to keep in mind the PTK and some lasers are different than the others. So just remove less and finalize the scrape with a spatula. It's a good idea.
All right, Professor, thank you. Next question from Dennis, Dr. Dennis Visconde from Philippines. How often do you do topography after LASIK surgery?
I do every time. In a week, I like to do a topography. In a week and a month. I usually see the first day, first week, first month, 3, 6, and 12 months. I like to do in a week. You have to do in a month. And I would say, with the wisdom that I got from the Smile Ectasia case, you should look at tomography as well.
All right, Professor, thank you. Next question from Dr. Leila Giasian. Dear Professor, Dr. Leila is from Iran. Dear Professor Renato Ambrosio, do you believe in superior keratoconus? If yes, how you consider that the preoperative considerations in refractive surgery? Thank you.
This is an interesting topic. Thank you for this question. Superior ectasia is possible, but many of the cases with superior stiffening, they don't have ectasia. So you have to look at the tomography and eventually biomechanics and thickness of the epithelium, etc. But superior keratoconus, actually, we have a few cases with superior ectasia, one of them with a true superior pellucid, which is really rare. And this is possible. This is possible. But like inferior keratoconus, you have to look at the epithelial thickness, you have to look at biomechanics, the elevation back and front, and this is not so simple. But even the anatomy of the eyelids and the narrow opening of the eyelids may be causing some influence on the corneal shape. So superior stiffening can be ectasia, but usually is not.
All right, thank you, Professor. Maybe this is our last question from my colleague, Dr. Kukuh Prasetyo. How about corneal hysteresis as a predicting for corneal ectasia?
Thank you for this question. Long story short, I was finishing my fellowship 2002. I was walking at the floor of the AAO, and I met a very nice gentleman, Dr. David Luce. He was the chief scientist for the ocular response analyzer from Reichert. And I connected with him since the first time, and he was telling me, oh, if you do refractive surgery, you should see my instrument because you will measure your IOP and correlate with the correct IOP, because if you do LASIK, your IOP is not going to be working well because you need to consider the cornea is weaker. The IOP should be corrected. And I looked at him, how you correct the IOP? Oh, we have, and he explained me about the corneal measurement that he was doing with the bidirectional mode with the non-contact tonometry. And I said, if you understand how to compensate the correct IOP, I don't care about IOP. I just want to learn very well how you compensate that, because this is a must for refractive surgery. And people don't realize that yet. And then we started a few conversations about it, and I started working with them. I got the ocular response analyzer back in 2004 or 5, the first prototypes. And hysteresis is a very nice term. Hysteresis means a delay from the first measured pressure and the second measured pressure. The air pulse that will give you the cornea to deform, and the cornea has an applanation, and then you record the pressure, the cornea goes down and then comes back, and then you have a second pressure. The difference between P1 and P2 is hysteresis, is the energy that the system has absorbed. So this is meaning lagging behind. Hysteresis means lagging behind, means a delay. So hysteresis is a very important factor for glaucoma, but not for keratoconus, because of the overlap is like this. So you need to change the understanding so that you have metrics from the deformation, so that you have a better separation for the dot plots, for the box plots in your populations. So hysteresis is important, but the waveform derived metrics that we got later, those are going to be much more important for understanding keratoconus. And we have many publications. If you put hysteresis in my name, you see probably all the work that we have done. That were 3 major postgrad that I helped going through this. And learning hysteresis was the first step for getting it. And the change that we had from ocular response analyzer, which is a great instrument, for the Corvis, which in my opinion is a better instrument, is 2. First, the air pulse of the air pulse that will hit the cornea with the Corvis is always the same. You always have the same puff. The ocular response analyzer, you have an air pulse that is going to be modulated by the first applanation. So if you have a higher pressure, you have a higher pulse. If you have a lower pressure, you have a lower pulse. So that change on the air pulse on the cornea make the deformation response that you will have less comparable, because you are hitting the cornea differently. The second thing is that the ocular response analyzer just have 1 point of measurement. This is the the light that shines to the cornea reflects back, goes through a pinhole, and then you have a sensor. And the shine fluid imaging that you have on the corveas, you really see the cornea. You don't see the reflex of the cornea. So you have much more data. Eventually, you can do better than the corveas with the OCT, and a higher definition shine fluid imaging or the OCT may give you more information than what we have today. But we also have other technologies to measure the corneal structure, which is related to Brillouin. And this is something that is exciting to see how it's going to develop.